Hello and welcome back to my channel, Juice It with Zita. Today I am going to be talking about my annual lab results. You know how passionate I am about my health. And the only thing that can tell me if I'm doing the right things or not are my lab results. So I did my annual physicals yesterday, and let me tell you the truth. I was a little bit panicky when I went to do this because I know I have been doing the right things. And the only thing that will confirm what I've been doing are my lab results. You will realize that when you go to meet your doctor after doing your tests, the meeting is usually very short. They just go through your lab results and tell you this is abnormal, this is abnormal, this is abnormal, give you a few recommendations and give you some pills if you need it. And I have realized that this has not been of help to me. So I have my first daughter here with me. She just finished her first year of pharmacy school, and I want to pick her brain a little bit. I want her to break down these results for me and give me a score so that I know that I'm not flying blind. So please help me welcome Mary-Ivy Kunchidi, first year student of MCPHS, Boston, Massachusetts. So here I have my first daughter with me, Mary-Ivy Kunchidi. She's a first year student of Massachusetts College of Pharmacy and Health Sciences. So mom, and I'm sorry, we call her mom because she's named after my husband's mother. So from time to time, I may switch between Mary-Ivy and mom because it's whatever comes naturally to me. That's what I'm going to use. So please excuse me for that. And before she comes up, I just want to make a little disclaimer here. She is not yet a pharmacist. She has just been in pharmacy school for 1 year. She has 3 more years to go. But I think she still has some nuggets that we can benefit from. So like what she's just going to break down is just going to give us an idea of what the numbers speak to and what you can ask your doctor when you go to meet your doctors after your physicals. So mom, take it on.
Hello everyone, thank you for having me on the channel today. So pretty much what I see here from a brief overview, there are ranges that could go from either normal or abnormal, but I would know what is normal and abnormal and how to help a patient because obviously I have that knowledge, but a lot of people are not obviously educated in this sector. And so the most one we worry about as clinicians is mostly your hemoglobin levels, your glomerular filtration rate, especially being diabetic. I'm going to start off with the glomerular filtration rate. The perfect filtration rate is about 120 milliliters per minute. And that pretty much means you're reabsorbing what needs to be reabsorbed, like your glucose. So you can have metabolic processes going on in your body, but you're excreting pretty much all the garbage, which is a lot of things going to your body, and your kidneys do a lot of work, pretty much figuring out what should go and what should stay. Another big thing to look into when you look at your lab results are your creatinine levels as well as your albumin levels. Albumin is we pick on it in healthcare because albumin is one of the major proteins. There's 5 major proteins in your body. The most major one made by your liver is albumin. And it has to be reabsorbed because you need to use it over and over again. Your body is very smart because your body reabsorbs and reuses things. If it's not broken, we don't fix it, right? So your body reabsorbs what needs to be reabsorbed, and then garbage is what needs to be garbage. And so if there's albumin in your urine, that's indicative of liver failure. But obviously, it's a compounded failure. It's not, albumin is not the only determinant factor of liver failure. But that's one of the things where if I see that on a lab, if I see you have albumin past a certain number, it gets worse because that's supposed to be reabsorbed. Your body's supposed to be using that. So if you're peeing that out, then that's like an alarming, like, hey, what's going on? Creatinine, it's indicative of kidney failure. So you want your creatinine levels within the normal range, but I am at a level of 3.63 millimoles per liter. So would you say that is an optimal level? Anything under 4, to the best of my knowledge, is optimal. But yes, creatinine, albumin, your glomerular filtration rate, especially being diabetic, you have to really pay attention to that because being diabetic, your nephrons, which is the major functional unit of your kidneys, are are already working at a disadvantage. So when the expectation is set at a certain bar when you're diabetic, but if you are at, let's say, 90 milliliters per minute, that becomes worrisome because you're really just excreting everything that comes in. And that's why diabetic patients have polydyspnea, polyuria, where they're very thirsty. They're drinking a lot of water, but it's like it comes in and then it goes out.
Oh,
but
no.
that is because...
I'm sorry to interrupt a little bit, because I remember when I got diagnosed with diabetes, one of the symptoms that I experienced was being very thirsty, drinking lots of water, and then using the bathroom multiple times, especially at night. So that was one of the symptoms. So that had to do with the creatinine level that I had?
Not necessarily. The creatinine is the glomerular filtration rate. Because
oh, okay. That's too difficult for me to pronounce. I'll leave it at that. But
the
at least I know
the GFR is...
Oh, the GFR.
Yeah, that's the short form of it. But I want to say point of reference is always make sure you hydrate, because the more hydrated you are, the less work your kidneys have to do. Your body has compensatory mechanisms, which are great. But when you're in what we call a disease state, you're working at a disadvantage. So in that light, you would want to be as hydrated as possible. Early signs of diabetes, like I said, even though it's very complex, is the transporters that are supposed to reabsorb all that glucose, they're not working. And so that's why certain medications like your Janumid and your Januvia, they mimic those transporters by making them act like, hey, we're friends. So let's reabsorb that glucose, because you don't have glucose, a lot of different processing in your body. You can't make ATP. ATP is what gives you energy. You don't got glucose, you can't make that. So just to pretty much keep this simple, GFR, pay attention to that albumin. Albumin of 0 is perfect. Albumin of 1, perfect.
What do I have? Let's look at my results here and see what I have based on that. So our creatinine here,
3.63 millimoles per liter,
and 4 is optimal. So I'm in the good books there.
Albumin
okay,
is 0.
Albumin is 0 for me. So I think I am in the good books. Would you say that?
Yes, I would say you're in the good books.
And I think most of what this is all about is about how much my system can detox, can take out the waste that it naturally produces in my cells. And from my results, it shows that my detox is top notch. My liver and my kidney are functioning really well. So thank you for that. The next thing that I think we can look out is the cholesterol, the lipid profile, which is another thing that raises a lot of attention.
Of course. So we have good cholesterol and bad cholesterol. Your LDLs are your bad cholesterol, but they really only become bad when they start building up in your arteries. That's why we start having the arteriosclerosis and the atherosclerosis and the statin drugs. That's what leads to all that. But normally LDL from our ancestors are supposed to be good for you, and our body is designed to store fat. That's why it's so difficult to lose weight, because carbs like bread, rice, fufu, they're all 3.4 kilocalories per mole. You can burn the fufu you ate yesterday in a 30-minute workout easily. The fat you can't burn as easy as possible. That's why it's so, like I said, it's so much more difficult to lose fat, but it's easier to lose carbs. But please don't go eat carbs, because that becomes a problem also. But when we come down to the LDLs and the HDLs, what happens is it's over time that this fat builds up in your arteries, and then we have a heart attack. Or you go to your lipidologist, which are the experts in looking at these numbers, and they say, well, your LDL is this and your HDL is that, or there's other ones, the VDLs, but the most ones that are concerning, especially your LDLs, because the low density lipoproteins, they pretty much are carried in this little cute packages, and they go to other parts of your body, because fat does a wide variety of functions in your body. And so when you have like your LDLs and your HDLs, they work great, but if you can do what you can to keep those levels as low as possible, it helps you in the long run, because a heart attack is a silent killer. You could be building up that fat for even 20 years and you don't know.
And you mean the fat in your arteries, right?
Exactly.
Because this fat that builds up in your arteries, the LDL it has an affinity to this fat. So it combines with this fat and it forms plaque.
Exactly.
And that is what constricts or reduces the size of your blood vessels and restricts blood flow, and that can lead to strokes or heart attacks.
Exactly.
If I'm accurate.
No, exactly.
Thank you.
The term is a myocardial infarction, because the myocardium is one of the main layers of the heart. And so if you can't get blood to that main layer of the heart, you're infarcted until you stop it. And then your heart is like, well, I'm not getting the blood. What am I going to do? And that's how you get a heart attack. So heart attacks are, funny enough, the most preventable, but it's the most I've seen so far in pharmacy school. It's the stats are deadly. But like I said, with the LDLs and the HDLs, there's lifestyle modifications, because again, to reiterate, a heart attack you don't see coming. You can have an emergency quick enough, thank God, you get saved. But you'll probably have to do some kind of bypass because of all the plaque build. It's kind of like a domino effect, that you could sometimes have to do a double bypass, a cabbage, what we call a cabbage in healthcare. And it just rolls over. So, the best things to look out for when it comes down to your lipid levels are especially your LDLs, because those are good until they're bad. That's how I call them.
I like the way you put it, because
they're good until they're bad.
Because I always say the LDL has been given the bad name for ages, but now recent science is showing that it's not as bad as it is, but keep it within optimal ranges. Exactly. So when you look at my LDL, what do you think?
Your LDLs are your LDLs are within the range that we would want them to be. And so within that light, I would still say, even though they're within the range, you can always work to keep them lower, because again, this is the one that raises up alarms when it's kind of pushing to that optimal range, but it's not yet there, but we're still looking at it because you got to keep it close enough. So yes, that's a one we pay close attention to when we're looking at lipid levels. The HDLs.
Just before you get into the HDL, what advice can you give? Like you talked about, you mentioned lifestyle. What advice can you give our audience to undertake in order to keep the LDL levels low? Because a lot of people have contacted me about having their annual blood work, like what I have here, and they have elevated LDL levels. So what advice would you give? What kind of lifestyle changes do they need to make?
Thankfully enough, right now it's summertime kind of in Calgary. I would say it's not necessarily, I know life gets busy, it gets difficult, but I always, my best bet to patients that I see is always take a walk. You got to walk the dog at some point, take a walk. While you're walking the dog, clocking your exercise. I have an Apple Watch, I clock everything on here as well. Even if you're at home, every hour, just stand up, go up the stairs, come. You can have a day if you're like, you know what, I just want to have a wind down day. I don't want to really do much. No problem. That's good. That's important for self-care purposes. But every hour, you know, pause the Netflix, go walk up the stairs, come down. That's exercise. Because once you sit it, right, especially going to your legs, you only have one way valves, because the blood is trying to go to your legs and then gravity is opposing. So if you sit for too long, even in airplanes, I know they tell me this when I'm flying, it's always stand up at least once every hour, because you don't want that blood to just be sitting. My pathophys professor always says, blood that does not move will clot. She said that line so much this year. And really, blood that does not move will clot. That's what causes stroke. That's what causes heart attack, because the blood is not moving. Blood is the only fluid connective tissue in your body. It's a fluid. If it does not move, it's stuck. There's nothing to get it through. So it's like, okay, I'll just relax here. I'll just chill here. But that's bad for you.
And not to interrupt you, we are sure and heart disease, cardiac disease, just because we have a very sedentary lifestyle at this moment. People sit, and it's summer. We have a lot of excuses not to go outside. It gets really hot during the day, and some people are on vacation. I can't wait. I just have a couple of days to go on summer vacation. But that should not be an excuse for people to binge on Netflix all day long. We should use this opportunity to keep active. And I love the fact that you brought up physical activity, which is very different from exercising. Exercising is really intentional and you're putting in the work. But you can incorporate physical activity during your day. Walk around. If you need to get the remote control, go get it. Don't tell the kids to get it for you. You need to go to the groceries, park away, far away from the store and take that walk. So there's so many ways that we can incorporate physical activity into our lives just to keep that blood flowing and avoid cardiac disease. Now we're moving on to the HDL. What are my levels?
Like I earlier mentioned, they are the good cholesterol, but they are not the biggest cause of concern because, again, they always label it the good kid, pretty much. So we don't always have too much of a problem with the good kid. Now, the good kid that turned bad, we have a lot of problem with that because the LDL levels, like I said, is what a lipidologist will look at it and write up a prescription for a statin drugs, your atorvastatins, your rosuvastatins, your simvastatins, your all those drugs, any drug that ends with a statin is what helps to lower your lipid levels. HDL, there's really not a lot of drugs out there for HDL because, like I said, our main focus is the good kid that turned bad because this is what is going to lead to atherosclerosis, arteriosclerosis, and then downstream a heart attack, potentially, or stroke. But you wouldn't want to put yourself in line for that, right? And also, if being diabetic, you are already, I don't want to say at a disadvantage, but for lack of a better word, predisposed. Thank you. That's the word. You're already predisposed to heart disease. You're predisposed to arteriosclerosis, atherosclerosis because of the disease state. But that does not mean that you can't put look at the levels I see here. That's what I see in someone that's not diabetic. Someone that I'm like, you're not diabetic. I don't got to worry about you too much. Honing on every patient I see. But I'm more so honing on the ones that are, I'm like, I know you're at risk of this, that. And so when I look at your levels, I'm like, okay, we could fix this. We could change this. We could turn this around. It's very possible, especially with the hemoglobin A1C levels. Those ones are, I think the biggest alarm for any clinician is, why is the number this? Why is the number this, right? And so when you are diabetic, we can't expect you, the goal in a perfect world, the euphoria, we want you to be at under 6.5. We know you obviously, because of how the disease state is, you can go a little bit more than 6.5, but we don't want you at like 15 because 15 now looks like a problem. And then, like I said, that becomes a whole downstream thing. So with the hemoglobin A1C levels, a very common misconception I get from a lot of people is, I don't want to eat the day of my A1C test. And I say this test measures over 3 months. Eat. What you're eating today is not going to matter. It's
just like feeding the chicken on the day you want to take it to the market.
Exactly.
It doesn't count.
Exactly. It's what have you done throughout those 3 months? And that said, you can't really see a change unless you give it some time. Like, with high blood pressure, a very common drug is lisinopril. It's mostly prescribed for a 90-day supply, which is you take one every day for 3 months. After 3 months, they go check your blood pressure and see what's happening. That's kind of almost the same thing that happens with most disease states. Most prescriptions are reading for 3 months. You can't really see a change after a week or 2 weeks. It's the same thing with even exercise. If you really want to measure how strong you are or how fast you've gotten, 3 months sounds about right. You've been doing it for about 90 days. It's a good time to check what's happening with that. But yes, the test I would recommend really paying attention to when you do your annual physical, and maybe to ask your physician or your P or your NP, whoever you see. Key questions are, if you are diabetic, the hemoglobin A1C levels. Even if you're not diabetic, still ask questions. What can I do? Because 5.7 to 6.4 is pre-diabetic. So if you're in the pre-diabetic stage, we can get you back down to 5.7, very possible, right? Through physical activity.
Good. Lifestyle and behavioral changes.
Some physical activity, at least. We live in a side of the world where everything is so accessible. Uber Eats, skip the dishes, car. I want to go down here. Car keys, zip, we're down there, we're back. It's convenient, but sometimes, you know, if the Dollarama is a 10-minute walk, it's nice out. 10-minute walk.
Put in the walk.
Gas is $2 a liter. 10-minute walk sounds good.
I like the gas part. Everything is getting crazy these days. But we still have to survive. So, Mom, looking at these results, what advice can you give me? What do you think about the results and knowing what I've been doing to control my diabetes? What can you say about my results and what advice can you give me?
For you, the only thing that is concerning, but not so concerning, is the A1C levels, which you are diabetic. I don't expect them to be under 6.5. But with what you're doing, I believe your next, because right now where it's at, it can't get to 6.5 in the next 3 months. It's very possible. I'm not worried about anything else other than that. The more you bring yourself towards that 6.5, the lower the dose of what you're on, you know, but the higher it is, then that's a change in therapy most times, right?
On a scale of 1 to 10, where would you rate me on my physicals, my annual physicals?
Do I keep the
A1C?
Do I keep the A1C?
Oh yeah, I'm diabetic, so keep it in.
Okay,
yeah.
So you're sitting at actually a 9 for me.
Wow!
Because the albumin levels is what I worry about most times, because that can lead to liver failure. The creatinine I also worry about, but you are the A1C levels is the last thing I'll look at for you. But
thank you very much, Ivy. I think I've learned a lot from our discussion today, and I bet my audience too will confirm that they have also learned a lot from what you've said today. I must say, you are pretty knowledgeable for a first-year student. I admire the amount of knowledge that you have and the confidence with which you put that across. I am really proud of you. I think in 3 years' time, we are going to be having a very astute doctor here. So thank you very much for watching. And if you want to know what I've been doing to control my blood sugar level, to look healthy, to have so much energy at the age of 44, I think I feel my best ever. Come back to my channel. Look at what I'm doing. It's mainly behavioral and lifestyle changes. I exercise very vigorously. I watch what I eat. I am on a strong plant-based diet, fulfilling relationships. Like, there's just a lot that goes on, and I have a very structured life that saves me the trouble of having decision fatigue. So struggling with keeping up with lifestyle changes. I am a certificated integrative nutrition health coach and a certified juice therapist. If you want to have assistance with having a healthy life, please contact me and we can make this happen. Thank you for watching. Have a good one. Be healthy. And thank you for coming.
Bye.